Hello everyone, this is Dr. Shama Tuzara, and today my topic of discussion is IHC markers of mesothelioma. And this was one of my presentation when I was at clinical observerships in pathology at University of Chicago Hospital, and it's an amazing topic, and you would really enjoy it. So this is stick by it, dive in, and learn from the topic, and I hope you guys enjoy. So let's start. So we'll start the topic by first of all telling you briefly that what we would discuss in the video. First of all, the background of mesothelioma, its definition, epidemiology, etiology, the diagnostic criteria. Then we'll discuss the IHC markers of mesothelioma, what are the main categories of them, and main focus will be on benign versus malignant markers. And lastly, we'll discuss a sample case to apply the IHC markers for the diagnosis of mesothelioma and how you actually implement them and how we interpret them. Uh, let's start. First of all, background of mesothelioma, what it is, it's basically a malignant neoplasm of mesothelial differentiation, of course, suggested by the name. It arises from the mesothelial lining cells of pleura, 85 to 90% of the cases, peritoneum in just 10 to 15% of the cases, and rarely it can arise from pericardial or paratesticular locations. What is the morphological classification? 2021, WHO classified mesotheliomas into three major types: epithelioid type, sarcomatide type, and the biphasic type. Talking about its epidemiology, incidence varies by the geographic location, and every year in United States 2000 to 3000 new cases are diagnosed of mesothelioma. Regarding its mortality rate worldwide, 28,000 to 43,000 people they die from malignant pleural mesothelioma every year. And it's important to recognize that which populations are affected by this tumor. So they are mostly elderly patients with a median age of 63 to 70 years, and male predominance is seen. 75 to 87% of the patients we see are mostly males. So it's important to know about epidemiology to better understand the disease, which why it is important, where it is most common, which populations are most likely affected, and which gender is most likely affected. So it's all about epidemiology. Moving on, the etiology, which are the most common causes of the tumor. So firstly, it's the asbestos exposure. Most common association with mesothelioma is asbestos exposure. Just a key home message to remember. And the latency period from the asbestos exposure to actual development of disease is very long, so it's like 20 to even more than 40 years, depending on how much severe and the duration of exposure it was. Second important etiological agent is the radiation, the ionizing radiation, which mostly patients receive for Hodgkin lymphoma therapies, non-Hodgkin lymphomas, and testicular cancers. Thirdly, the close family members in patients with malignant pleural mesotheliomas, they are also prone or more likely to have mesothelioma. Then molecular aberrations, this is less common in just 12% of the cases, but what are the mutations? BAP1 in 1 to 4% of the cases, and MSH3, BARD1, RECQLR4, BRCA2, MRE11A, and SHQ1. This is just 1% of each is affected by these. So, diving in to the diagnostic criteria. First of all, morphology, what we see under the microscope, that is the cornerstone for diagnosis, followed by IHC findings that supports our diagnosis and further classify into types and malignant versus benign and all. Thirdly, molecular studies, FISH, and targeted sequencing panels. And lastly, it's important to correlate the clinical, radiological, and operative findings together to make a good diagnosis. IHC markers. First of all, what are the main goals? So first main goal is to establish the lineage, the mesothelial lineage. Second is to distinguish mesothelioma from the malignant mimics. And thirdly, which is important, is that mesothelioma needs to be distinguished from malignant or from the reactive mesothelial proliferations, and that means it's the benign malignant markers. So these are basically the three aims for the IHC markers which we have to interpret. First of all, talking about the lineage markers, there are five important lineage markers: calratinin, CK56, WT1, podoplanin, also called D240, and HEG1. So each of these markers, they are more than 80% sensitive for epithelioid mesothelial proliferations. However, it has lower sensitivity for sarcomatide proliferations. Just excuse me. So moving on, the lineage markers. First of all, we'll dive in deeper into each of the lineage markers. Calratinin. Calratinin has strong and diffuse positivity here, and combined cytoplasmic and nuclear staining is important. So this is an example of calratinin stain on a mesothelioma tumor. So as we see here clearly, these bright brown dots as perfect globular areas, that is the strong nuclear staining. See the nuclear, and the light brown areas surrounding those dots is basically the cytoplasmic staining. And it's clearly shown here that it's strong and it's diffuse everywhere, and it's both nuclear and cytoplasmic staining positive for calratinin. Second, CK56, it's just cytoplasmic staining, and 91% of the epithelioid mesotheliomas have it. Then WT1, this is an example of it. It has nuclear staining, only nuclear staining, clearly seen here. These dots, these are the brown dots, are positive nuclear staining, and in 88% of the epithelioid mesotheliomas. Then the cytoplasmic only staining, it should be disregarded and completely ignored because it's just a background staining in WT1. Moving on to the podoplanin D240, it shows membranous staining, and in 93% of epithelioid mesotheliomas, this is its example, the linear membranous staining showing podoplanin positivity in mesothelioma tumor cells. Then HEG1, it is more specifically used to differentiate it from other lung tumors, and membranous it shows membranous staining, and this is the example of HEG1 stain, which shows this strong membranous staining in the tumor cells, and it is seen in 94% of epithelioid mesotheliomas. Now we'll move on. First we discussed the lineage markers. Now we'll move on to the benign versus malignant markers, means the markers which actually distinguish it as either benign or as malignant. So we have four major markers. These are very important, so please stick here and listen carefully and try understanding them. So first is BAP1, MTAP, Merlin, and 5-HMC. So, what is BAP1? BAP1 is BRCA1 associated protein 1. It's located on chromosome 3p21.1. It's a tumor suppressor gene, and it acts as basically a deubiquitinase, which associates with multi-protein complexes that are required for regulation of the key cellular pathways. So, if BAP1 is lost, then the cellular pathways won't be regulated, and as a result, uncontrolled cell growth, proliferation, abnormal cycling ultimately lead to tumor development. So next step, how we interpret the BAP1 stain. First of all, nuclear staining loss, if it's lost within the nuclei, that is considered as positive. The cytoplasmic staining is considered irrelevant, and positive associated with better prognosis. And we look for if a patient has BAP1 staining positive, then our next step is that it has a better prognosis, and we look for germline mutations in the patient. It's 100% specific for differentiating malignancy from the reactive mesothelium. 50 to 60% it's sensitive for pleural mesothelioma, relatively higher for peritoneal mesothelioma, and this time BAP1 is greater for epithelioid mesotheliomas as compared to sarcomatide or biphasic types. Now it's important that it is also can be lost in some other tumors other than mesothelioma, and it's important to know them for better awareness of what you are seeing. So it is also lost in melanoma in BAP1 syndrome and in a small subset like less than 1% of renal cell cancers. Now this is a good example in which BAP1 is lost in. So this is BAP1 is lost. So this is are the mesothelial proliferation tumor cells. These cells highlighted by the arrow and by my pointer. When BAP1 was applied, see, no nuclear staining seen here. All the blue areas, no brown staining within the nuclei. That indicates that BAP1 is lost here, and the other is just the background staining. So this is another example in which we do see the mesothelial proliferation cells within these are basically the mesothelial proliferation, and when BAP1 was applied, clearly we see that there is no nuclear staining seen here, all these blue areas, and the remaining surrounding these cytoplasmic granular staining, it is just considered irrelevant and that should be ignored. So this case there is also BAP1 lost. Now, the second important stain, that is the MTAP. MTAP is called methyl thioadenosine phosphorylase. It's a protein involved in purine metabolism. Reasonable alternative for homozygous deletion of CDKN2A, which was both costly and time consuming. So MTAP is now replacing that. Significance of MTAP. How we can interpret it? BAP1 we know before was nuclear loss considered positive. Here, if cytoplasmic loss occurs, then that is considered positive. Okay, and positivity is helpful for diagnosing it as malignant mesothelioma. And thirdly, what is the significance of okay, so what is the significance of MTAP lost in mesothelioma patients? So it make the patient eligible to enroll in a trial of a new targeted therapy. So basically it's therapy oriented stain that's helpful in that way. And internal control is important, that it should be positive, that the stain should be positive internally, staining inflammatory cells and the stromal cells, that while in the presence of that positive internal control, if tumor cells show loss of cytoplasmic expression, that is considered as a true loss and indicates that the stain is actually working. So, interpretation of MTAP. Now, I've already discussed how it's interpreted, and it's 100% specific for malignancy in differential with reactive mesothelium, and 50% sensitive for pleural mesothelioma, and 5 to 10% like less sensitive for peritoneal mesothelioma. Hence, sensitivity is greater for biphasic sarcoma type than epithelioid type. While in BAP1, it was more sensitive for epithelioid type as compared to the biphasic sarcoma type. Again, it's important to know that where other this tumor can this stain can be lost, and that is the other malignancy like sarcomas or carcinomas. Now, MTAP retained. So this is basically the case of the mesothelioma. Here we see the mesothelial tumor cells, and when MTAP was performed, see strong cytoplasmic staining means MTAP is retained. Moving on, in other tumor, when MTAP was performed here, it's clearly lost. No cytoplasmic stain within the tumor cells that indicate that MTAP is lost. This is another case of a sarcomatide type mesothelioma tumor, and here again no cytoplasmic staining seen here. These are the background stains, so it's lost MTAP. It's important to take in consideration the background inflammatory cells, and that suggests it's a positive internal control, but does not. But that should be ignored when the stain is interpreted in terms of tumor. So this is all the background inflammatory cells, while the tumor cells see no staining within the tumor cells. So MTAP is lost. Moving on, the third stain, that's Merlin. Merlin is NF2. It's a tumor suppressor protein encoded by NF2 gene. Interpreted, so it's retained or either lost. Retained means that tumor cells are stained positive for Merlin, and here the distribution and intensity of staining, it doesn't matter. It is either just positive or negative. Okay, and it is also positive in reactive mesothelial proliferation, while lost means that tumor cells are not stained by Merlin, while adjacently some other tumor cells stain positive, or background inflammatory cells stain positive, both suggesting that stain is working correctly. It's a positive internal control, but the tumor cells are negative, indicating that Merlin is lost here, and it is lost in 49% of mesotheliomas. Moving on, and now this is a case where we see that these are the mesothelial tumor cells, and here when staining was performed, see this membranous staining and cytoplasmic staining is positive within the tumor cells, indicating that Merlin is retained. This is another example of a case of mesothelioma where Merlin is lost. That is, it patient has NF2 mutation, and these are the tumor cells. And here we see that no Merlin is stained here within the tumor cells, and these are all the background inflammatory cells, suggesting a positive internal control, but yet needs to be ignored for diagnosis, for interpreting the stain. Last stain is the 5-HMC. It's called 5-hydroxymethyl cytosine. How it is interpreted, it is retained means nuclear staining is positive, and if it's lost means it's complete loss of nuclear staining in each cell in the presence of a positive internal control, like adjacent tumor cells are stained positive with it, or nearby stromal cells are stained positive. And cutoff value, so if more than 50% of the cells show loss of 5-HMC, then it is considered as malignant. Less than 50% is not considered significant for commenting that it's malignant tumor. Now again, it's important to see that whether it is lost in other tumors or not. So it is also lost in biliary adenocarcinomas and melanomas. So this is the stain, which is a combined double stain of CAM 5.2 keratin and 5-HMC, in which the red chromogen is the CAM 5.2 and the brown chromogen stain is the 5-HMC stain. Both sarcomatide and epithelioid tumor cells, they express cytoplasmic keratin, and effectively we do see here, like see these tumor cells, they are positive for red stain, which is 5 CAM 5.2 means keratin positive, but no nuclear staining seen with the brown stain. So it's 100% loss of 5-HMC. This is another case in which we do see the red staining of keratins of the tumor cells. These are all the tumor proliferations of mesothelial cells, but in some cases we do see that this nuclear brown positivity is seen in some cases. So this indicates that, and when we calculated the percentage, 35% of the tumor cells were positive for 5-HMC, and that does not meet the criteria, so it is insufficient for diagnosis of mesothelioma. Lastly, we'll discuss a sample case. It's a 72-year-old previously healthy male with history of asbestos exposure, developed with persistent bronchitis, weight loss, right-sided chest pain, and exertional dyspnea over 6 months. Imaging was done. It showed right hemithorax volume loss, mediastinal shift, and progressive nodular pleural thickening. Thoracocentesis fluid was negative for malignancy, and patient underwent core needle biopsy of the pleura. On differential diagnosis, this is like the histology. We do see, like see the spindle shaped tumor cells, indicating either it's a sarcomatide mesothelioma or it's a reactive type. Here we'll apply one of the stains which would help us in leading the diagnosis later on. Now here we also saw some bland necrosis within the tumor cells. See tumor cell trickling around the fat cells, indicating fat invasion. Later MTAP was performed, and these sarcomatide cells show no nuclear staining, so MTAP is no cytoplasmic staining, I'm sorry, and MTAP is lost. How we interpret it, that since MTAP was applied and it's lost, it support that it's a malignant lesion, and lineage markers were supporting for mesothelial lineage. So in combined, we made the diagnosis that it's a sarcomatide mesothelioma. And this is basically a sample example where we actually implemented what we studied throughout the whole lecture. These are my references of all the topics we discussed in all the slides. Some of the slides which I took from these references. So these are just my memories from my rotation at University of Chicago. It's a beautiful building. I really took some nice pictures. I like photography when I'm free. Some nice pictures. This was my first day. I was sitting on the scope at Dr. San's office. We got some badges there in one of the end of the lecture. Beautiful building. This was my when I was observing the grossing there. And again, a nice building, a nice memory, a good fresh day. So, a great time we spent there, learned a lot. So at the end, I would like to thank my mentor, Dr. Hussain. She is an amazing person. I learned a lot from her, and she gave me the opportunity to present this topic. And I learned mesothelioma from her throughout her rotation, as she's like this is her specialty, and she has good command on the topic. It was great, and thank you so much to her. I really wish in future I become a mentor and a pathologist like her. So thank you everyone for your patience. I hope you liked the video, and if you did, please like it and share your reviews in the comment section. And for all the seniors and all more expert people watching it, if you I'm sorry. Do apologize me if I did anything wrong, and feel free to contact me in the comment section and tell me if I can improve, whether in delivering, way of presentation, and if I did something wrong, do correct me out. Your feedback would be really important, and thank you in advance for all that. And look forward for the next video. Good luck, everyone, and have a great day. And thank you so much for coming up till the end of the video. So. Bye bye. Take care.